Good morning. I'm James Ng, urogynecologist from Malaysia. My talk is on assessment and clinical diagnosis of pelvic organ prolapse and its implication on treatment options. This is the outline of my talk. Starting with some basics, pelvic organ prolapse originate from the Latin words prolapsus, which means slipping forth. According to IUGA ICS Joint Report, pelvic organ prolapse is defined as the descent of one or more of anterior vaginal wall, posterior vaginal wall, uterus, or vaginal cuff after hysterectomy, which should be correlated with symptoms. As you can see from the picture here, this allows nearby organ to herniate through the vaginal space, which can be the cystocele, rectocele, or enterocele. As we know, pelvic organs are supported by the muscles and connective tissue of the pelvic floor, the endopelvic fascia, the ligaments, and the fibromuscular tissue of the vaginal wall. Professor Delancey classified the pelvic support into 3 levels. Level 1, which is uterosacral cardinal ligament. Level 2, which is the endopelvic fascia, and level 3, which is the perineal membrane and perineal body. Female pelvis can be divided into 3 compartments as well. The anterior compartment where the bladder sits, the middle compartment where the uterus and cervix is, and the posterior compartment where the rectum and the anus is. These are some pictures from my clinical practice. You can see here anterior vaginal wall prolapse, commonly representing the bladder, posterior vaginal wall prolapse, which commonly representing the rectum. And this is uterine prolapse, where the cervix is clearly seen. And in women that had hysterectomy, it will be a vaginal wall prolapse. It is very important for us to know damage at different levels of pelvic support will lead to different clinical presentation. Damage at level 1, which is the uterosacral cardinal ligament complex, will lead to uterine or vort prolapse and enterocele. Level 2 damage, which is the pubocervical fascia anteriorly, will lead to cystocele. Rectal vaginal fascia posteriorly, which leads to rectocele. And level 3 damage, which is the perineal membrane anteriorly, which will lead to urethral hypermobility, which is stress urinary incontinence, and perineal body posteriorly, which will lead to perineal seal. As in any other clinical condition, assessment and clinical diagnosis of pelvic organ prolapse can be divided into history, examination, and investigation. These are some guidelines that I found it useful, and I use it for this presentation. The NICE guideline on urinary incontinence and pelvic organ prolapse by the United Kingdom, and the ACOG and AUGS practice bulletins on pelvic organ prolapse by the United States. As we know, women with pelvic organ prolapse most commonly presented to us with prolapse symptoms such as vaginal bulge, pressure, pain, fullness, discomfort, dragging sensation, low back pain. Some may even need to spleen or digitate during defecation. In advanced prolapse, women may complain of bleeding, discharge due to ulceration and infection. 2/3 of women with pelvic organ prolapse will present with a combination of symptoms such as urinary symptoms, bowel symptoms, and sexual symptoms. They complain of frequency, urgency, incontinence, voiding difficulties such as slow stream straining, incomplete voiding, and urinary retention, constipation, straining to defecate, incomplete bowel emptying, and some might even have coital difficulty. Questionnaire is a useful tool for screening, diagnosis, severity and bothersome quantification, and to compare pre- and post-op treatment result. This questionnaire should be validated should be reliable and reproducible. It is translated and available in different languages, and we can even email it to our patients prior to consultation. For pelvic organ prolapse, example of questionnaire are pelvic organ prolapse distress inventory, pelvic floor impact questionnaire, and even Australia having their own Australian pelvic floor questionnaire. It is important for us to know what are the risk factors for pelvic organ prolapse so that we can modify the risk factor. Risk factors for pelvic organ prolapse are age, parity, mode of delivery, menopause, obesity, history of hysterectomy, connective tissue disease, and increased intra-abdominal pressure, such as in chronic cough, chronic constipation, heavy lifting. Moving on to examination, which consists of abdominal and pelvic examination to rule out pelvic masses, ascites, evaluation of external genitalia and vaginal epithelium, such as vaginal atrophy, ulceration, assessment of the pelvic floor muscle, which consists of tone, strength, perineal reflex, and of course, cough stress test and occult stress test to unmask stress urinary incontinence. According to the Oxford grading system, pelvic floor muscle strength can be graded into 5 scores, with 0, no contraction, 1, flicker, 2, weak squeeze, 3, fair squeeze, 4, good squeeze, and 5, strong squeeze with a lift. History have shown us that gynae examinations took place in different ways. Especially in urogynae, we examine women in lithotomy position, in sim position, in standing position. We ask women to cough, to laugh, to jump, to demonstrate certain symptoms such as stress urinary incontinence. There are many systems used to quantify pelvic organ prolapse. However, in year 1996, pelvic organ prolapse quantification system has been created. It is a standardized system for pelvic organ prolapse assessment, and it is the only validated method for objective measurements and documentation of pelvic organ prolapse that is recommended by International Urogynecology Organization. What are the advantages of POP2 classification? It is precise, it is objective, it is reproducible, it encourages consistency in reporting, facilitating communication between providers, and it also allows pre-treatment and post-treatment comparison. So what is POP2? It seems to be very complicated for a lot of clinicians. It is actually 9 measurements presented in a 3x3 grid method. As you can see here, the blue circle represents anterior compartment, the green circle represents the central compartment, and the purple circle represents the posterior compartment. In the central, we have 3 measurements, which is the genital hiatus, perineal body, and total vaginal length. All these measurements are recorded during Valsalva, except total vaginal length. So these are the 9 measurements in POP2. We might need to use ruler to measure them. Again, AA, BA is your anterior compartment. Your point C, your point D is your central compartment. Your AP and BP is your posterior compartment. The definition is given as is shown here. So according to these measurements, we can clinically stage any pelvic organ prolapse, which is stage 0, 1, 2, 3, and 4. Measurements are recorded in centimeter relative to the hymenal ring. The landmark in POP2 is hymenal ring. At hymen, it will be 0. Beyond hymen, it will be positive, and anything above the hymen will be negative. So the prolapse stage is defined by the vaginal structures that demonstrate the greatest degree of prolapse. In AUGS website, there is a PopQ interactive assessment tool where you need just to put in all the 9 measurements and they will give you a clinical picture of how the pelvic organ prolapse looks like. So again, this is how PopQ looks like in stage 0 where there are no pelvic organ prolapse, and this is how stage 4 pelvic organ prolapse looks like. Moving on to investigation. In general, no additional testing beyond a complete gynecologic, urologic, and defecatory history and physical examination is needed before treatment. Indication for additional testing are advanced pelvic organ prolapse for those that are beyond hymen, combination with other symptoms such as lower urinary tract symptoms, bowel symptoms, sexual symptoms, and prior to invasive treatment or surgery. Patients with pelvic organ prolapse that have urinary incontinence, I might do a urine dipstick to rule out infection. Patients with overactive bladder, I might do a bladder diary. And patients with voiding dysfunction and recurrent urinary tract infection, I will need to do a post-void residual. Urodynamics will be helpful in patients that are with stress urinary incontinence, unclear type of urinary incontinence, and voiding dysfunction. We all know bladder capacity and post-void residual can be measured using conventional ultrasound or bladder scanner. Bladder volume equals to a width times the depth times the height times a coefficient. Usually we use 0.7. With the advancement of technology, imaging has gained more role in the management and diagnosis of pelvic organ prolapse and pelvic floor dysfunction. Ultrasound and MRI has gone beyond in advancement, and it is helpful in imaging of pelvic organ prolapse. Ultrasound can be in the form of transvaginal, introital, transperineal, or endoanal. So as you can see here, in ultrasound imaging, the landmark is symphysis pubis. Anything below the symphysis pubis will be a prolapse. As you can see, a cystocele here, a rectocele here, and a uterine prolapse here. So I will show you a clip and you might need to tell me what is the spot diagnosis. Correct. It is an enterocele. A bowel is herniating into the pouch of Douglas. What are the other functions of imaging in helping the diagnosis and management of pelvic organ prolapse? I use them to differentiate diagnosis. When a woman presents to me with anterior vaginal mass, is it a urethral diverticulum? Is it a cystocele, or it is a Gardner duct cyst? As you can see here, the multiplanar imaging, there is a connection between the urethra and the mass. Thus, it is a urethral diverticulum. Besides that, I would use tomographic ultrasound imaging to look for levator avulsion. As you can see here, there is levator avulsion over the left side, and I may use rendered imaging to look for hiatal ballooning. Ask my patient to perform a Valsalva. As you can see, the ballooning. All these are risk factors for pelvic organ prolapse recurrence after surgery. I can use this information for my patient counseling. Any one of you, if it is interested in pelvic floor imaging online course, it is available on the IUGA website. So this is my personal protocol on pelvic organ prolapse management. I will start with the history taking, moving on to examination, and end with investigation if necessary. Finally, implication on treatment. As we know, there's a wide range of treatment for pelvic organ prolapse, ranging from no treatment to non-surgical and surgical treatments. What are the factors to be considered? The stage of prolapse, associated symptoms, patient age and health status, perioperative risk, further childbearing desire, coital activity, history of previous surgery, patient's preferences and expectation, and of course, expertise available. Surgical treatment for pelvic organ prolapse can be performed vaginally or abdominally. Now we have laparoscopic surgery, we have robotic surgery. It can be a repair of the anterior compartment, the central compartment, or a posterior compartment. It can be a restorative surgery, obliterative surgery such as colpoclysis, where we close up the vagina, and compensatory surgery where we use meshes or graft. It can be a uterine preserving surgery, or we can perform a hysterectomy. At the same time, for women that have other symptoms, such as stress urinary incontinence, we can choose to perform a concomitant surgery or a staged surgery. This is a summary of all the surgical treatment available for pelvic organ prolapse by the American Urogynea Society and IUGA Society. So as you can see, it can be a reconstructive surgery, obliterative surgery, uterine preserving or hysterectomy, and with graft or using native tissue. So, take-home message. Assessment and clinical diagnosis are important in the management of pelvic organ prolapse. We need history taking, physical examination, investigation to reach a correct diagnosis, and for optimal treatment. Prevention is better than cure. Identify and modify the risk factors. The severity of pelvic organ prolapse is not equal to the degree of bothersome. Different patients tell different stories. Quality of life assessment is important. And finally, assessment and treatment of pelvic organ prolapse should be individualized. I hope you enjoy the rest of the conference and hope to see you in Malaysia. Thank you.